Exact data on the incidence and prevalence of sciatica are lacking. In general, an estimated 5 to 10% of patients with low back pain have sciatica, whereas the reported lifetime prevalence of low back pain ranges from 49 to 70%. The annual prevalence of disc-related sciatica in the general population is estimated at 2.2%. Most patients with acute sciatica have a favorable prognosis, but only about 20 to 30% have persisting problems after 1 or 2 years. The diagnosis of sciatica and its management varies considerably within and between countries. Disc surgery may provide quicker relief of leg pain than conservative care, but no clear differences have been found after 1 or 2 years. This video was originally intended as a review after attending my course Effective Treatments for Sciatica. Recent improvements and additions have allowed me to also include the lecture. So now, for those people that have not attended my course, will be able to see the course in its entirety. Although it is effective working on skin with minimal lubrication, many of the participants in the instructional demonstrations are wearing clothing, and interestingly enough, it is still very effective. One day, I was watching a cadaver dissection study of this region by Auckland, and I came to some interesting realizations.
Here's the sacral plexus. It's formed by the anterior rami of L4 and 5, and S1, 2, and 3. The sacral plexus overlies the piriformis muscle. This is the sciatic nerve. It arises from L4 through S3. This is the superior gluteal nerve. The inferior gluteal nerve arises out of sight behind the sciatic nerve. All 3 nerves leave the pelvis through the greater sciatic foramen. To see where they come out, we'll go round to the back and remove gluteus maximus. Here the vessels have been removed to simplify the picture. Here's piriformis. Here's the sciatic nerve. Here's the inferior gluteal nerve. And here's the superior gluteal nerve, disappearing beneath gluteus medius. The superior gluteal nerve supplies gluteus medius, gluteus minimus, and tensor fasciae lata. The inferior gluteal nerve supplies gluteus maximus. The sciatic nerve runs down the middle of the thigh. Deep to it are quadratus femoris and lower down adductor magnus. This is the long head of biceps femoris, which crosses over the nerve obliquely and covers it up. We'll follow the sciatic nerve further in the next section of this tape. In the thigh, the sciatic nerve supplies semitendinosus and semimembranosus, and also biceps femoris and the posterior part of adductor magnus.
The sciatic nerve at its thickest point is approximately the diameter of your small finger. One of the first things that I noticed was that almost every image that you're ever going to see of this region, the sciatic nerve leaves the center of the pelvis and it goes laterally of the ischium bone and medial to the greater trochanter as it goes down into the leg. But in this video, that's not actually what we just saw. What we just saw was a sciatic nerve went directly over top of the ischium bone. My understanding is that this is very rare. I also treat a lot of cyclists and triathletes. In the arrow position with tiny little racing saddles, they are primarily putting most of the pressure of their body on the pubic ramus. And I thought they were putting more pressure onto their ischium bone, but it turns out that they're really not. I had done a study with the Trek Bike Corporation, and we found out they're not putting as much pressure on their ischium as I thought. So with this information, if you happen to be treating a person that has a pain going down their leg when they sit on a hard wooden chair without much of a cushion, there's a chance that they could be one of those rare individuals that their sciatic nerve goes right over top of their ischium bone. The best way to counteract that, other than performing surgery, which would help to displace that nerve off of that vulnerable area, is to have the person sit with a cushion. Another thing that I noticed from the video was the sciatic nerve, as it goes down into the leg, it actually goes through the medial and lateral heads of the hamstrings. So in that situation, all you have to do is have tight hamstring muscles, and it literally could compress the sciatic nerve. And most everyone feels that sciatic nerve problems originates in the lower back or the gluteal region. And I've just found two areas that doesn't quite correspond. So that taught me that I need to concentrate more on hamstrings than I ever did before. In some cases, up to 50% of my treatment time will be used with hamstrings. If you'd like to check out any of the other videos by Dr. Auckland, they're produced by Lippincott, Williams, and Wilkins, each showcasing different areas of anatomy. Throughout my research, I found that most acute back problems are self-limiting. Around 90% will get better within 6 weeks, regardless of the treatment they receive. Bed rest is almost never of value for nonspecific pain. But if you look at many people that are suffering with this, precautions from their physicians a lot of times will include, don't do very much, just lay around, don't strain your back. Between 2 and 8% will develop chronic symptoms, that's all. And as always, most people can point to a single event. They all seem to think it's just one thing or another. They don't realize that it's usually a combination of many different contributing factors. Throughout my years, there's been many teachers of mine, instructors, mentors, and a few special people that have allowed me to really see things in a different light. One of those special people is Carol Hartigan. She's the head of the New England Baptist Spine Hospital's Back Therapy Clinic. In her clinic, she will see the worst of the worst back patients you've ever seen in your life, the ones that nobody wants. They have had multiple spinal fusions, Harrington rods inserted, and constant chronic pain. And Carol will take up to 2,000 patients a year, and her results are amazing. Carol has felt that fear avoidance behavior and reduced activity levels are common. She said, let's not guard it and protect it anymore. It's the opposite of what they've been told. If you have a bad back, it should be strong, flexible, and fit. Patients that are accepted into her back program will see her for 6 weeks. From the very first day, she'll have this person bend over if they can, pick up a weight, bring the weight back up to their chest, and place it on a bench. and then do it again. And these people are screaming, crying in pain. And yet the most interesting thing is they're sore, they're complaining, but all of a sudden they're starting to move again. These muscles are starting to fire again that haven't fired in years. And over time, the 6-week period, almost every single patient will say that they're functioning at a higher level, and in many cases, they function without any pain or very little pain. Her results are amazing. If you'd like to contact Carol, I've included her email address at the Spine Center and also a previous study she did with Dr. Rainville. Amazing clinician. Carol lectures at Harvard regularly, and she's very well respected in the medical community. Another one of the big influences in my career is Vladimir Janda. Dr. Janda is known for the upper and lower cross syndromes. I see that type of condition all the time. People that are in tremendous back pain, they end up walking into my office just like that person here. Their hip flexors are tonus, they're hypertonic, they're too tight. The opposite side of the body is a weak or phasic type of condition. So by strengthening the weakened areas and stretching and releasing the tight areas, the person will be in better balance, and it works. The biggest problem is looking at how all of this happened. Dysfunctional habits that contribute to this too. Another one of my influences is Ben Benjamin out of Cambridge. Ben has taught me loads about scar tissue and the effects of ligament damage of the body. He's always told me that if it's an acute condition, then it's always muscular. If it's a chronic condition, it's always ligaments or, in some cases, tendons. Ben was quoted in saying that the low back is the most commonly injured part of the body. I could understand that because that's primarily what most of us treat. The next statement that he said, I looked at him and I said, Ben, what are you smoking? I have never heard a crazy thing come out of somebody's mouth. He said, the most common low back injuries is sacroiliac ligaments. And I go, what? I didn't understand it at the time. So he said, if you were to look at the spine, the main support is the sacroiliac ligaments. He kind of explained it like a skyscraper. That if you look at a skyscraper that's very tall, as it gets closer to the earth, it gets wider. The fewer floors as it gets to the ground is wider still, so it's a nice broad support. And he said the spine is just the same thing. The cervical vertebrae are smaller and narrower. The thoracic vertebrae get larger, and then the lumbar get larger still, and that connects with the pelvis, which is larger still. So the pelvis, in a sense, is the main support for the spine. And I go, okay, I can understand that. And the sacroiliac ligaments surround the sacroiliac joint, which connects the pelvis to the spine. With that, I could understand that. So showing him much respect, more to be determined later. If you'd like to contact Ben, he's at benbenjamin.com. He was in Australia a few years ago, and there were some interesting videos of him working with a patient. You might still be able to find it, .au. Also an interesting article he wrote on ligaments of the sacrum. If you were to go into forward hip flexion, this is what it looks like. So if it's shortened in the front, then it's opened up or it's lengthened in the back. What that ends up doing is that it kind of puts a little bit of tension on the posterior sacroiliac ligaments. It's not really an issue because ligaments have a tensile strength of well over 2,000 pounds per square inch. They don't stretch, they have a little bit of give to them. The problem is that if we're in extreme hip flexion for long periods of time, multiplied by many years, those ligaments become strained. It's the same thing if you were to take a rubber band and place it around your fingers. Then if you were to pluck that, you could pretty much twang that rubber band no problem for as long as you want. But if you were to open your hand and stretch that rubber band and then try and pluck it or twang it, eventually it's going to break. Why? Because it's under tension. It's the same thing with these ligaments, that over time, built up, these ligaments become strained. And if they become strained, that literally is the main support for the spine, and it helps to support the sacroiliac joint.
The sacrum of your spine is attached to each ilium of the pelvis. These joints are called the sacroiliac joints, or SI joints. Each joint is encased and strengthened by strong bands of connective tissue called ligaments. These ligaments allow approximately 2 to 4 millimeters of movement during weight-bearing and forward flexion. When these ligaments become damaged or worn down by age, they allow the joint to have excessive motion. This excessive motion inflames and disrupts the joint, resulting in sacroiliac joint syndrome. Symptoms can include pain in the lower back, buttocks, and thighs, as well as difficulty sitting.
This video had a nice visual of the sacroiliac joint and how it's encased in ligaments. I didn't care much about what he said, the body deteriorates with age. I hate to think that we're deteriorating. The function of a ligament is to hold and support the joint. A ligament has a tensile strength of well over 2,000 pounds per square inch. That's like steel. A ligament does not stretch. It has a little give to it. And a ligament does not get very good blood supply. So if it happens to get injured, it doesn't heal very well at all. If you look at the anterior pelvis and sacroiliac ligaments, there's almost no dysfunction with this region whatsoever. It holds the joint very well, and it's not very much of an issue most of the time. Now compare that to muscle. Muscle has a tensile strength of over 600 pounds per square inch. It's not as strong at all. Muscle is very vascular, so when it gets injured, it has a tendency to heal much quicker. Muscles do stretch. That's one of their main functions as they flex and extend. So 9 times out of 10, muscle is not usually the issue. The issue, especially with chronic conditions, is that it's usually always ligaments or also tendons, which are made up very similarly to ligaments. If you turn the body around and look at the posterior region, it's totally different. The posterior sacroiliac ligaments, which is just medial to the posterior superior iliac spine, will find 3 layers of posterior sacroiliac ligaments. 3 layers. That's over 6,000 pounds per square inch. Then we have the ligaments that cover the sacrum. There isn't 1 layer of sacral ligaments, there's 3 layers. That's over 6,000 pounds per square inch. All of those merge with the sacrotuberous ligament, which attaches to the ischium. There's been a lot of data supporting sacrotuberous dysfunction. I feel it's just a stabilizer. The issue is just above it. I also asked the question, why are there 3 times as many ligaments on the back than the front, and almost no dysfunction with the front? It's all in the back. There's a type of injection therapy called prolotherapy. Prolotherapy has been used since almost the beginning of medicine. It consists of saline solution, dextrose, B vitamins, and lidocaine. These doctors that use this will inject around the ligament. What it initially does is causes an irritation or inflammation of the collagen matrix of the fibers of the ligament. As this irritation or inflammation subsides or heals, some of these doctors claim that it can actually tighten up the ligament and helps to heal dysfunction. It's very controversial. Some doctors say prolotherapy is not effective, that you're better off just using the cortisone injections to help to heal that dysfunctional ligament. I was talking to a doctor out of close to Chicago, and I told him that I'm planning on doing this course on sciatic pain, and he said, I recently just completed an interview on video on sciatica. If you'd like, I'll send you a copy. I said, sure, I'd love to see it. I saw this video, my mouth hit the floor. I couldn't believe it.
What is the best treatment for sciatica? Well, most of the sciatica we see, it's not from a nerve injury. Like if you go to a regular doctor and you have pain down your leg, right away they think your sciatic nerve is being injured. Well, I can just tell you, if your sciatic nerve, if you have true sciatica, the pain is like unbelievable. It's a 10 out of 10. So if you can sit here and talk to me during an interview, you know, and you can smile, even though you have some pain, you know, it's doubtful you have your sciatic nerve is getting pinched, like from a herniated disc or a bone spur. 9 times out of 10, people have what I would call pseudo-sciatica. In other words, they have pain down their leg, but it's not from a sciatic nerve injury. It's a referral pain from a ligament injury. The most common ligament injury that causes sciatica is an injury to the sacroiliac joint. So I'd really encourage people to look at the Hackett referral patterns, because a sacroiliac ligament problem will cause sciatica down the leg. So if a person has pain on one side of the lower back, like in other words, they say that their lower back pain, it's not in the middle, it's just on one side, then it's most likely that they have a sacroiliac ligament injury. And the referral pattern, pain pattern of a sacroiliac ligament injury is on the side of the leg down into the lateral toes. So most traditional doctors don't realize, even some physical therapists don't realize, that ligaments refer pain to a distant site. So you could have a hip ligament injury and have foot pain or heel pain. You could have a sacroiliac or lower back ligament injury and then have pain down the leg. So anyone who's had surgery or a lot of comprehensive care in their lower back and their sciatica and or their lower back pain hasn't resolved, most likely you have a ligament injury, because ligaments don't show up on X-ray, you know, or MRI. So that's why it was missed. And really the treatment that you need to resolve the sciatica or pseudo-sciatica is prolotherapy. So definitely prolotherapy, a great treatment for sciatica.
He is the second doctor that's told me it's coming from the sacroiliac ligaments. I couldn't believe it. I really started to focus on it a lot more then. He also spoke about pseudo-sciatica. Out of the thousands of people I've treated for sciatic pain, how many would I say were true sciatic sufferers, what he describes, that it was a direct compression on the sciatic nerve? To be totally honest, none. It was always a secondary pain referral. It was never a 10 out of 10. He also spoke about ligaments referring pain. I guess I never focused on it very much because we were always taught that muscle refers pain. Ligaments do have innervation as well, but not as much as muscle. If you'd like to contact Dr. Hauser, he's at caringmedical.com, Oak Park, Illinois, and there's his email address for you. As I continued my research on low back pain and sciatica, I wondered about the connection of the sacroiliac joint and why was there 3 layers of ligaments in this dysfunctional posterior pelvic area. I came across this image and all of a sudden, all of the dots started to connect. We all know the effects of sitting and the strain it puts on the back. But in this image, I saw so much more. It wasn't just the sitting posture, it was how the person was sitting. They, in a sense, were slouching. One day, while I was waiting for my flight at LaGuardia Airport, I noticed this woman sitting next to me. Oh my goodness, and those chairs don't encourage you to sit straight. This was comfortable for her. This image was of a gentleman attending my course before my class even started. Look at him. I started noticing more and more people sitting in that dysfunctional pattern. How did we get this way? Our ischium bones, along with being the site of muscle attachment, they're commonly known as our sitting bones. If we're sitting correctly, most of our pressure is being put on our ischium. But in a slouch position, most of our pressure is being put on the posterior sacral area and sacroiliac ligaments. And it's not just how we sit, it's how long do we sit. Prolonged sitting, the single most stressful event in the low back, which puts all of the weight of the upper body on the sacroiliac area. This posture can lead to tight hip flexor muscles that encourage weakness of the low back. And then we start getting into the Dr. Yanda thing, that if the hip flexors are tight in front, then it's going to be tighter in the lower back. Bending in the knees in this position will cause the hamstring muscles to get even tighter, which pulls the ischium downward that further strains the low back. And we already know that the hamstrings are a big player in this because the sciatic nerve goes in between them. Then we look at the effects of poor posture. Poor posture will magnify the strain on the vertebral discs and sacral ligaments. So how does this poor posture usually start? Many times, poor posture habits are sometimes ingrained from an early age. And look at this young child. In another 10 years or so, just imagine how tight her neck is going to be. Many causes, including being tall in height as a child, not being encouraged to stand up straight, and of course, wearing high dressy shoes a lot of times will throw the pelvis off, which causes the rest of the body to compensate for that too. Homer Simpson illustrates inadequate support is a big problem. Weak abdominal muscles don't allow the spine to stay balanced evenly on the pelvis, causing more pronounced spinal curvatures. Relaxing and soft furniture will eventually influence posture, which weakens supporting structures of the spine. I don't know why it's so comfortable just to lay on a couch at the end of a long day, to where couches, in a sense, were made to be sat in, to where beds were meant to be laid in. And 9 times out of 10, we just don't utilize that like we're supposed to. Flexibility and mobility is also a very big contributing factor as well. If you were to look at this position, it would be difficult for most people to have much extension in their back, to try and get their anterior superior iliac spine to touch the floor when they're in this cobra position. And 9 times out of 10, the reason why is because a lot of times they just don't do it very often. Now, they'll certainly go into flexion when they're driving a car, when they're sitting in chairs, but 9 times out of 10, most people go into flexion a lot more than they go into extension. So by creating a little bit more balance will mean so much more as far as the flexibility and pressure on the spine. Poor flexibility. The body responds to poor flexibility by altered or limited mobility. This change in mobility results in unnecessary stress on the joints, poor circulation, and weakness of other muscle groups. So, starting the assessment process, before the musculature of the low back can be examined, we must look at the movements we should be capable of. I'm primarily interested in movements of the hip and also of the back. The gentleman that I asked to come in for this assessment, his name is Frank. Frank is a retired factory worker, a retired sewing machine repairman, and an avid golfer. This man lives to golf. He literally will be out on the course all day long. And he started developing sciatic pain going down his left leg, to the point to where he can hardly swing a golf club now, and his wife is so happy. She says, don't fix him. So he finally came in to see me, and I asked him to do some basic range of motion movements. So it's a passive movement. I'm doing the moving for him to where he's not actively engaging his muscle. If he actively engages the muscle, it points more to the muscle or the tendon, to where if he's staying relaxed passively, a lot of times it'll point more to the ligaments. So the first motion I wanted him to do is just hip flexion. With hip flexion, I just had him bend over. It's more of an active motion, but no problem with that. With extension, I asked him to place his hands on his lower back to protect his back and just ask him to move back in extension. Not too bad. Maybe his gut got in the way a little bit. No pain. Next is rotation. With rotation, I'm doing the motion for him. Rotate to the right, no problem. Now watch the left. If you notice that, he couldn't rotate as much to the left, and when he did that, it fired down his hip, down his leg. Did you see his hip jiggle? So that told me it's coming from the ligaments on the left side. Next is hip movement, hip extension. With this, I asked him to put all of his body weight on one foot, and then I move his other leg backwards in extension. No problem. It's not great, because a lot of times we never do this, because we're always in flexion. Hip flexion. With this, in the supine position, I bend his knee and flex his hip. No problem. Sometimes a little tightness of the glutes, but he was okay. If there's a knee issue, you could have the leg straight, which is the actual assessment for sciatic pain, the straight leg test. When I did that on the left side, it did fire down into his hip. External rotation of the hip. So with this one in the prone position, bending the knee, bring the knee out to the edge, and then drop the foot. Good range of motion. He does yoga occasionally, but no pain. Internal rotation of the hip. So with this one, same position, now we just bring the foot outwards instead of inwards. No problem. It's not as great. We don't do that as often as we do external rotation of the hip. Adduction of the hip. In the supine position, simply bringing the leg over to the other side. Sometimes they're IT bands or their hips or the lower back, but he was fine with this. Hip abduction. With this, simply bringing the leg out to the side, no problem. Sometimes their adductor muscles are kind of tight, but he was okay. So with Frank, I got lucky on this one, that what I found was that he had a trigger point that was referring from his lower back on the left side, and also his left sacroiliac joint that referred down his leg. So I placed him in the opposite position. I had him rotate to the right, which felt okay. And then I started fishing around into the left lower back and sacroiliac joint area, and I found a trigger point that referred down his leg. So I worked that for a few seconds, let it relax, went to other areas, found a trigger point, let it relax, and I went back and forth between those areas for about 30 minutes. Gave him a nice stretch on the left side of his IT bands and his lower back on the left side, and the man is back to playing his golf again. I try to utilize assessment as much as I can. With Frank's condition, it saved me a lot of time and it pointed me in the right direction. I ask a series of questions and answers. When did you first notice the problem? Can a certain movement reproduce any pain? If you used any previous treatment, was it helpful? Any muscle aches, tension, or problem sleeping? I ask, how do they feel when they wake up in the morning? If they're stiff, a lot of times that points to you need more support in your mattress. You could help that just by placing a piece of plywood in between your mattress and box springs. You don't even notice much difference until you wake up the next morning and all of a sudden you don't feel quite as stiff. All it takes is a little bit extra support. Be sure to address any type of contributing factors. Encourage the person to make lifestyle changes if many of the factors are on their list. And always try and encourage them to have more activity. This next area of assessment is similar to muscle testing. I prefer to call it functional assessment. So we've kind of gotten an idea as far as the ligaments. Now I'd like to focus more on muscles and also tendons. So it's an active movement. Resistance or pressure from the therapist is only 1 to 2 pounds. It's almost nothing. With muscle testing, there's usually a lot more force that's involved. But I find this will point you in the right direction without as much strain for the person. Direction of resistance also follows the black arrows on the illustration, and the assessment is performed for a maximum of 5 seconds. With trunk extension in the prone position, with the head and upper trunk extending off the table from about the nipple line, the arms are at the side. The therapist is standing at the side of the table. The lower extremities are stabilized just above the ankles to help to protect their lower back. The subject extends their spine, raising their body from the table so the umbilicus clears the table. Instructions you can read to them: raise your head, arms, and chest from the table as high as you can. This is only held for 5 seconds. If they have a problem with this, or if there's any pain involved with this, then that usually points to the area that helps with trunk extension. Trunk flexion. In the supine position with the hands clasped behind the head. If that's too challenging for them, they can do grade 3, which is the arms are outstretched in full extension above the plane of the body. Standing at the side of the table, the lower extremities can be stabilized just above the ankles. That helps to take pressure off of their lower back. The subject flexes the trunk through a range of motion. A curl-up is emphasized and the trunk is curled until the scapula clears the table. Instructions: tuck your chin and bring your head, shoulders, and arms off the table as in a sit-up. Trunk rotation. Supine with the hands clasped behind the head. The therapist is standing at the side of the table. The lower extremities can be stabilized just above the ankles. The subject flexes the trunk and rotates to one side. This movement is then repeated on the opposite side. So it's 5 seconds for each side. Instructions: lift your head and shoulders from the table, taking your right elbow towards your left knee and reverse. Hip extension in the prone position. Standing next to the limb, the hand to give 1 to 2 pounds of resistance is placed on the posterior leg just above the ankle. The opposite hand could be used to stabilize the pelvis at the sacrum. The subject extends their hip. Resistance is given straight downwards to the floor. Instructions: lift your leg off the table without bending your knee and don't let me push it down. Hip flexion. Seated position with the thigh fully supported and their lower legs are hanging off the edge. The therapist is standing next to the limb, the contoured hand to give 1 to 2 pounds of resistance over the distal thigh just proximal to the knee. The subject flexes the hip, clearing the table. Instructions: lift your leg off the table and don't let me push it down. External rotation of the hip. Sitting on the table, supported by the hands. The therapist kneels beside the limb to be treated. The hand that gives resistance grasps the ankle. 1 to 2 pounds of resistance is applied as a laterally directed force at the ankle. The other hand, which offers counter pressure, is contoured over the lateral thigh just above the knee. Resistance of 1 to 2 pounds is given as a medially directed force at the knee. The subject externally rotates their hip. Instructions: don't let me turn your leg out. So the person goes into external rotation and holds it, and you have to try and push them out, pushing in with the knee and out with the ankle. 5 seconds for each side, and medial rotation is the exact opposite. So they hold medial rotation in, and you have to try and push them out of it. Hip adduction. Side-lying position with the test limb resting on the table. The uppermost limb is supported by the therapist by cradling the leg with the forearm. Standing behind the subject, the hand giving resistance to the lowermost limb is placed on the medial distal part of the femur. The subject adducts the hip until the lower limb contacts the upper one, using 1 to 2 pounds of resistance. Instructions: lift your bottom leg up to your top one, hold it, and don't let me push it down. So you're cradling the upper leg like a baby, and they have to bring their bottom leg up. That's the one that you're assessing. And make sure you do the other side. Hip abduction. Side lying with the test leg uppermost. The lowermost leg can be flexed for stability. The therapist is standing behind the subject. The hand giving resistance of 1 to 2 pounds is contoured across the lateral surface of the knee. The other hand is used to palpate gluteus medius and minimus. The subject abducts the hip without flexing the hip. Instructions: lift your leg up in the air, hold it, and don't let me push it down. Assessment of the pelvis. If the person is laying supine face up, if their legs are extended, I want to get an idea to see if one side of the pelvis is translating or pointing more anteriorly than the other side. I'm not speaking of a rotated ilium. I'm speaking of the pelvis as rotating in one plane or one axis as a whole unit, with all of the bones that connect the pelvis, the different bones together. If you were to superglue all of those joints together, then you have one bone, the pelvic bone. And it's not uncommon to find one ilium is projecting more forward, and in this case, more anterior. As in this picture here, one side is projecting more anterior. If that's true, then the opposite side of the body and the posterior side is projecting more posteriorly. I keep that in the back of my mind, and a lot of times that's what I focus on. So if the left ilium is projecting more forward, the right posterior ilium is projecting backwards. And that's usually what I'll try and work. That usually means that the left anterior hip is going to be tighter and the right posterior hip is going to be tighter. It doesn't always work out that way, but about 90% of the time. The calf muscles. I don't have to start here, but I guess it's probably more of a habit of just starting distally and end up working more proximal towards the center of the body. Also, how much does the calf muscles influence sciatic nerve pain is questionable, but if you remember, Dr. Hauser did say that a condition could go down into the lateral toes. So with gastrocnemius, the lateral head is usually a little bit longer and a little bit flatter, to where the medial head is a little bit thicker. It also has more of an attachment point onto the tibia. Depending on the person, if they have a tendency to walk with more pressure on the outside of the foot or the inside of the foot, that could influence the development of the calf as well. I'd like to go against the grain if I can. You're going through the fibers instead of just stroking over top of them. If it's possible to have the leg off the edge of the table, then it doesn't put much pressure on the ankle. By pushing the foot into dorsiflexion, it causes the muscle to stretch. It's a great way of working that. It encourages that elongation as you're working it. By having the person actively dorsiflex their foot themselves, it sends the nerve signal to the front, to the tibialis area, and allows the back to let go.
So we start with gastrocnemius. I'd like to spend more time here, but I just don't have the time because hamstrings are going to require so much more. I usually find that the medial hamstring is most dysfunctional. It attaches onto the tibia, has a larger attachment. It helps to stabilize us more. So I usually end up working the medial side a little bit more. So we start with nice gentle strokes in here. I go to kind of like this tissue barrier where I kind of feel where I can't push really anymore without causing discomfort, and I just wait for it to let go. If you're sensitive enough, you can feel this kind of let go. As it lets go, then you can actually go deeper into the next layer. It's kind of like if you were to make a fist and place your finger on your skin and then just release your fist, you can feel that change, that difference. That's what I'm feeling. The problem is, over the years of destroying my hands, I've used my hands way too much. And I've finally realized, after working on these large people all day long, don't use them anymore. So now, and it has a much larger contact area, I'm all about using my forearms. And I'm in a nice relaxed position. There's no strain in my body whatsoever. I could be eating a sandwich right now. I could be reading a book. And you finally get this after destroying yourself for 25 years. Is the pressure okay?
Yeah, it's tender.
Okay. So you want to work within their tolerance. It can be uncomfortable, but it should never be painful. A therapist that works on a person that they're sore the next day, then they worked way too hard. The person should not be sore the next day. I also like to work against the grain of a lot of muscles. So if it runs north and south, against the grain would be east or west. And I find with the medial head, to go medial to lateral is the most effective way. It's a little more aggressive, but you might have to lighten up a little. Up there, I'm using my hands again. Stop that. So now back to forearms, and it releases this faster. To release the lateral head, you would go lateral to medial. Is that okay?
Yep.
And it releases really fast. Try and remember that one layer at a time. The body has approximately 10 different layers to get to in the legs. And it doesn't take long. If you're patient enough and gentle enough, the person's body, you can kind of feel it release and it'll let you in.
Is that something you've learned throughout the years? Or did somebody say?
There are so many different other techniques that are really helpful out there. They're all tools. Like in sports medicine now is active release technique, to where you're stretching the muscle as you're working at the same time. Great technique. Many others. Muscle energy technique, there's so many others. So with active release technique, you're stretching the gastroc as you're working at the same time. A movement that I like to do, my contribution is, I like to call it dynamic extension. Dynamic extension is because you work on so many people that are so out of touch with their body. They never realized it was so sensitive because they've just lost awareness of areas of their body, especially athletes. So with those people, what I do is I bring their leg off the edge of the table and I tap on their tibialis anterior. So that tells them I want them to contract this muscle, and when they do that, they go into dorsiflexion. That stretches this. And then they relax, and then keep doing it. Do it nice and slow. So as she's contracting the muscle here, relax again, then I'm working the gastroc as it's being stretched. Neurologically, she's sending the signal here. So it allows this to let go. It's kind of like P and F stretching. But the great thing is they're becoming more aware of this area. And now for the best reason, I have to work half as much because they're doing all the work. And they're becoming more aware all the time. It's a little bit more aggressive, so you might have to lighten up a little. but it's a great way of releasing any area of the body. And you could even ramp it up even another notch and do that against the grain as they're doing dynamic extension. Gets in there, doesn't it?
Yeah.
So great way of working that area.
With hamstrings, I usually start working hamstrings a similar way to the calf muscles. To go against the grain, it's more aggressive, so you might have to lighten up a little bit. The medial portion of hamstrings, there's more resistance if you go from medial to lateral. On the inside portion and the outside lateral head, if you go lateral to medial. The inside portion of hamstrings, if you go medial to lateral, there's more resistance. You're going against the grain more. If you find any adhesions or speed bumps, try and smooth those out. Try and go through them instead of bouncing off of them. On the outside portion, it's the reverse. So it'd be lateral to medial to go more against the grain. Going with the fibers, elongating that tissue. With their knee off the edge of the table, if they contract their quadriceps, while they're doing that, you can stroke up the muscle or go against the grain, and you can actually get deeper into the tissue with less discomfort. The common hamstring tendon just below the ischium bone is a very chronic area for some, and just by cross-fiber frictioning it will help to release that. Building the hamstrings inside out. The most superficial hamstring muscle is semitendinosus. On some individuals, you'll really be able to feel the ridge going from the ischium to the inside of the knee. If I start just medial to that ridge, I'm going laterally, going through the muscle, it'll relieve a lot of hamstring issues.
Hamstrings will cramp at a moment's notice if you use way too much pressure. One of the most dysfunctional areas of hamstrings is the common hamstring tendon just below the ischium. It's a thick cable. With a lot of athletes, they'll tear it on the inside medial portion. So I just use my fingers to cross fiber back and forth. Is that pretty sore?
Nope, not at all.
And by going against the grain and cross-fibering it, it's breaking loose those fibers, especially if there's any scar tissue built up there from past injuries. Up, there I am using my fingers again. So now it's time for Mr. Elbow. So sink in nice and slow. And because I'm using a specific point with my elbow and I'm leaning in with my body weight, I might have to really lighten up on my pressure. So just ask them if that's too much. Is that okay?
That's fine.
And just cross fibering back and forth. If this is really sore on them, then you're going to need to spend more time there. But the average person, not too bad. But you still need to check that spot. Next is just to work the hamstrings as they come down like this. So favorite position, back to my sandwich, reading my book. No strain in my body whatsoever. Nice big contact area. Pressure okay?
Yep.
So it can be uncomfortable but never painful. To release the medial portion to go against the grain, it would be medial to lateral. And to release the outside portion, it would be lateral to medial. And you could bend the knee and then move the leg over to work more of that medial lateral position. So then I get into, you can sometimes feel speed bumps. Speed bumps are where the muscles have actually stuck or adhered together, and by going against the grain of these speed bumps, it'll actually separate them, And all of a sudden you'll feel it's like, that's gone. It feels so much better. So what I'm going to do with hers, I'm going to see if I can find one of those knots. So by bending the leg, it's not too bad. And some people, some tight individuals, you'll feel like a cable. Looks like that's about it.
Oh, that's my good leg.
Oh, okay. So what I'm feeling is that there's a restriction here that's about this long, and it's kind of running north and south. So what I'm going to do is I'm going to place my forearm straight down into this area, and then I'm going to move my forearm in a different direction. Like I'm going to lean medial, lean lateral, superior, inferior. And it seems like if I were to lean more lateral, then I'm kind of going up against the edge of that. You feel that?
Yep.
Sensitive?
That's just the tighter spot. Yeah, that's sensitive.
So it's kind of like a brick wall. It's going north and south. And I'm just leaning up to on the edge of that brick wall. But you have to not use a lot of pressure. You kind of feel like a tissue barrier, and I'm just waiting. As this releases, like I showed you with my fist, then it'll let go, and it allows me to go into the next layer. But don't get too aggressive. Then you got to wait for that layer. When that lets go, then you go into the next layer. So every time it releases, then I can use a little bit more pressure.
So you can feel from your elbow?
From your forearm, yeah.
No. Oh,
I'm not using my elbow, really. I'm just putting all my pressure right there. So it looks like it, but I'm really not. The way I kind of see this is kind of like if you wanted to go visit your friend at his office building for lunch. So you go to your buddy's office building at lunch, and it's 12 noon, and you look and his door is closed. So what are you going to do? The polite thing to do is to just knock on the door, and he'll come and he'll open up the door and say, let's go to lunch. Good to see you. The rude, obnoxious thing to do is what? Just open the door and say, I'm here, let's go to lunch. It might be interrupting him, who knows what's going on. So when you're working on the body, you want to be polite, not rude. So you go to one layer and you wait. Just knock on the door, and within about 10 to 15 seconds, they'll come and let you in to that next layer. But don't get too aggressive. That's only one layer. It's one door. Then just wait, and they'll come and open the next door. So that's how you can get into the body really deep, but it's not that uncomfortable or painful. People comment to me they can't believe I'm so deep into their body, and yet it's not painful. And all it takes is just patience. Just takes time. I know we just don't have a lot of time to do this, but is there any way that you can describe this to people, what this is like? The pressure?
It's your forearm, right? Not
Yeah.
your fist?
Yeah.
Right. It's,
Is it over the top? Is it too much?
no, it's, I would say, medium pressure, but it's a little bit uncomfortable, kind of like a little bit of a toothache.
Can you tell that I've almost like tripled my pressure so far from when I started?
No. I can't really tell where you are. You know, you've been there a while, so I've lost the sensation a little bit.
Yeah. But isn't this nice, though, that it's not over the top, that I'm not just really digging into there?
Yeah, this is much less than you were on the calf.
Yeah. And all of a sudden, I've started to travel just a little, so it means it's starting to let go. When it lets go, then I'll just slide off the edge. But if it's deeper, then it's going to keep me there for a while. So I'm pushing down, but I'm also pushing out laterally, too. I'm up against that brick wall. That's slowly letting go. There it goes. So this is just one of many. She literally could have hundreds of these adhesions in her hamstrings. But that one spot that we just worked on, it's non-existent. You don't have to go back and treat it again next week. It's gone. So there could be other restrictions that need to be worked out. But that's just one of many. And you want to be aggressive enough as far as pressure, but you have to be just patient and just wait. And give it time to release on its own, and it will. So you're working with the person instead of working against them. And they shouldn't be sore the next day. It's amazing how this works.
The lateral rotator tendons and the lateral rotator muscles. This is previously thought to be a very important area to treat. I might spend more time on cross-fibering the tendons and almost no time working on the lateral rotator muscles. If it's possible for the person to go into external rotation of the hip and hip flexion with bending of the knee, this will cause a little bit of tension on that sensitive area. From the greater trochanter, go just medial to that, the widest part of the hip, and those are the lateral rotator tendons. They can be very sensitive. Being careful about using your fingers and thumbs, because I have a tendency to wear those out too much, so this is a good spot for the elbow. But remember, be careful, this can be really sensitive. This is where most of the problem is. It's the attachment point, the tendons. They don't get a lot of blood supply, they don't heal well. The second part is going from gluteus medius and angling yourself down to the ischium bone. You're literally going against the grain out of all of the lateral rotator muscles, smoothing out any speed bumps, going really super slow. So that whole process is about 2 minutes. As you can see in this image, most all the lateral rotator muscles, they look like a fan coming off from the posterior greater trochanter. So you're going totally against the grain, and the whole area should release in approximately 2 minutes.
With the lateral rotators, they look like a fan and they all attach to the posterior greater trochanter. You don't have to put them in this position, but if you can, this will tighten this area up a little bit. So by bringing their knee off the edge of the table and then dropping their foot, if the foot doesn't want to stay in place, just put them into a little bit more hip flexion. Then we're going to concentrate on the area just posterior to the greater trochanter, which is right about there. So just by using a supported thumb position or tools and just any number of different directions you could go. Actually, it's a little easier for Mr. Elbow. But remember, you're using your body weight, so you might have to lighten up on your pressure a little. Is pressure okay?
It's tender. It's better.
So there's no special direction that you have to go in. It could be in any direction. You might have to just hold that spot for a second. It might refer. This might be an issue that you need to concentrate on for a while. Right about there. Good spot.
It's all tender.
That's a bad spot. So that spot kind of goes southeast. Everything attaches into this spot. It's a common lateral rotator tendons. Next is to go against the grain out of all these muscles. You could either go up or down. I usually prefer to go down. So I'm going to start about gluteus medius, and I'm going to go down to the center of the glute, and then I'm going to go over top of gluteus maximus, and then I'm going to end up at the ischium bone. So with here, going in very gently with Mr. Elbow leaning into it, going straight down. So I'm going to start this way. Since we're working on clothing today, because this is normally done on skin, so you want to make sure you drape them appropriately. So working on clothing, you might have to cup your hand around your elbow, and that'll help you to slide over clothing better. So we just allow this to let go. Shouldn't take too long. About in the center of the glute, the sciatic nerve is very superficial, is very exposed, so you might have to lighten up a little bit more.
Do you use a cream?
Just a touch, yeah, not much. Yeah, just to limit friction, but not much. After we get past that, the next spot we're going to come to is down here, which is going to be the lower portion of gluteus maximus. And it's a major speed bump. So we don't want to bounce over a speed bump. We want to try and bear down and go through it. I've also started to change my pressure a little. I started like this, and now I'm going to be coming in like this, and eventually I'm going to be coming in like that, because I don't want to just fall right off of it. So gluteus maximus, the lower portion is down here. So when you get to that, notice I'm not speeding up, I'm taking it nice and slow. This is a really sensitive area. But if you treat this well enough, you don't have to go back and do it again. One time's enough. Because we spent so much time on hamstrings. We're almost there. Now I'm changing my direction even more to go this way. Is pressure okay?
Yeah.
We're almost there. Oh, there we are. Lower portion of gluteus maximus, try and go through it instead of bouncing off of it. Then we're going to come to a nice flat spot, and then the ischial tuberosity. That's where we end up at. Okay, good.
The sacral ligaments. In some cases, dysfunction of the sacral ligaments could refer pain into the sacroiliac joint or also down into the sciatic nerve. If this area is hypersensitive, continue working on this until there's no sensitivity. This area could be sensitive because of falls as a child, epidural injections, or slouching too much. The sacral ligaments, we're just working on one side here, the left side, just working off of the midline. It's not very wide, maybe an inch or two in width. Just keep going deeper. Uncomfortable but never painful. As it starts to soften, you can go deeper. So where I find this region is just off of the center, and my fingers will go down to the coccyx where my finger falls off. The top of the sacrum is just below the posterior superior iliac spine, and you only go out maybe an inch or two just medial to the posterior superior iliac spine. Now remember, you have 3 layers to get through, so it's one layer at a time, and I'll cross fiber that for a few seconds and I ask the person, is it sensitive? If it is, then I back off a little bit. If it's not an issue, then I just keep going and work with the person, uncomfortable but not painful.
Next is the ligaments that go over top of the sacrum. So we're working the right side of the body, and then you can also see the seam on their pants too. So I want to be just off of the right side of that seam. I want to be off of the midline. At no point do I go anywhere near the posterior superior iliac spine. It is way too sensitive. So I walk down, I find the tip of the coccyx where my finger falls off. Then the posterior superior iliac spine is here, so I need to be in between these points. And I'm just off of the midline on the right side. So from here, by using your fingertips, try and support your fingers if you can. Then I'm going to go straight down into the body when there's kind of a response. As far as the tissue, then I'm not going to push down anymore. And I'm just going to sink into it, and then I'm just going to cross fiber, very small little move east and west. So if you don't have the fingers for this, then just use your knuckles. That works pretty good too. So just on this right side. So as I start, I'm using probably about 3 to 4 pounds of pressure. Is that pressure okay?
Yeah.
Some people, this is a real dysfunctional sensitive area, so this could require you 10-15 minutes to stay here. 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 10-15 min So you might really wear out your fingers at that point, because this could actually refer into the sciatic nerve. This could be the cause of it. So I'm just cross-fibering back and forth. As this releases, I'm going to use a little bit more pressure, and I'm going to keep going down. But remember, you want to be patient, not rude. You want to slowly get into that area. Is pressure okay?
Yes.
The problem is, the more pressure I'm starting to use, if you look at my body, you can see my shoulders are starting to creep up to my ears. This tells you that you need better leverage. So now I can get up on my toes, and it's better, but it's still not there. So this tells me I need to get up on the table. Now take a look at where my shoulders are. See the difference? So let your shoulders tell you if you need better leverage. If your shoulders go up to your ears, then you need to get higher. So with this, I'm directly over top of my fingers, and there's like almost no strain in my body whatsoever now. And if I need more pressure, I just lean into with my body more. This is so much easier on me than doing it the other way. And the best way, of course, is to have a hydraulic high-low table. And then I don't have to get up this high. Pressure okay?
Yep.
Is there any way you could describe to people what this feels like?
Very firm. It feels like knuckles. Is that what you're using? The fingers.
Fingers. Is it relaxing or is it uncomfortable?
It's uncomfortable, but not painful. Just
Okay, good.
very firm.
Every time that this releases a little bit, then I use a little bit more pressure. So I started with about 3 or 4 pounds. I'm up to about 10 pounds now. You can kind of see if you can see my fingertips, they're kind of turning white. So I'm using a lot more weight on here. Did you feel anything? Did you feel that release just now?
No.
No. So you're just off of the midline. At no point do you ever go anywhere near the posterior superior spine. It's way too sensitive. So after doing this for a good 60 seconds to 2 minutes with really good pressure, then you want to ask them, how sensitive was this? If it wasn't sensitive, then just go on. If it was sensitive and if it's uncomfortable, then there's a problem here. You need to continue. So how long do you continue until there's no more issue? So with her comment was that it was uncomfortable. So that means that you definitely needed to stay there a little longer on her and just keep doing that. And as I say, if you don't have the fingers for this, then use your knuckles or a tool or something.
The iliolumbar ligament. This nasty ligament has to be one of the most painful sensitive ligaments we have in our body. It attaches from the transverse process of L5 to the iliac crest. If you remember what Dr. Ben Benjamin said about a structure that goes more laterally, that's main support for everything above it. So in a sense, this is literally what happens. It's one of the main supports for the spine. It's dysfunctional and sensitive on just about everybody because this ligament is under constant tension and strain. Remember, ligaments don't get very good blood supply. And we might move our lumbar vertebra, but very rarely do we ever move our L5 vertebra and S1 independently. They usually move together. So this ligament is very sensitive. It's also challenging to access. Just to get to this ligament, it's 1 inch down into the body. It's just medial to the posterior superior iliac spine. Because of the sensitivity of this ligament, it might require multiple appointments just to be able to reach it. I hope this animation will help you to appreciate the depth of this sensitive ligament.
Next is the iliolumbar ligament. The iliolumbar ligament attaches at the transverse process of L5, and it's 1 inch down into the body just to get to it. So what I'm going to do with supported thumb position is go straight down, and by using her feedback, when she tells me that's enough, then I'm going to cross fiber north and south. And it's easy to find. You find the posterior superior iliac spine, go touch medial, and touch superior. It's right there. So in order to do this correctly, though, you need to really get good leverage to protect your body. So if this is the posterior superior iliac spine right here, then I'm going to go a touch medial, about 1 inch, and a touch superior, so about 1 inch that way. So it's an L. There, there. It's kind of a flat spot in the low back, so you're well above the hips. So in order to do this correctly, I need to have good leverage. To protect myself, so I'm up on the table, supported thumb position, and I'm going to go straight down. So PSIS, go a little touch medial, a little touch superior, supported thumb position, and I'm working with them. So you need good feedback. When they tell you that's enough, then that's when you cross fiber it north and south for 5 seconds. Ready? So you tell me when that's enough. Just go straight down. Then you cross fiber north and south. 5 seconds. So I'm just using my body weight to do the work, because there literally will be some people that won't say anything, and you have to keep going down to the basement to get there, because it's 1 inch down into the body. So we got maybe ½ inch on her. So we didn't even get down all the way to that ligament. Wasn't that uncomfortable?
Yes.
So there's no point in overdoing it. If you want to go back, you can do it again, but this will actually help her a lot, even though we just got in a ½ inch and cross-fibering it for 5 seconds. People comment to me, Gary, they feel like that's the epicenter of my problem, because all the pressure is right there in that ligament.
The sacroiliac fascia. The positioning of this will be the exact same as it was when you were cross-fiber frictioning the sacral ligaments. But instead of cross-fiber frictioning, you're just going straight down through the different layers of fascia. There are approximately 10 layers to get through. Minimum of 2 to 5 to 10 minutes for this. I prefer to use my fingers because it's very specific pressure. If you don't have the finger strength for this, you could use the heel of your hand, your knuckles, your forearm, and you go straight down to the tissue barrier and then just wait. It could be uncomfortable but never painful. As it starts to soften, go deeper into that area. You can go same side of the body, cross the body, but just keep going straight down into the center of the pelvis. People comment to me, it feels like my leg is getting longer. Positioning on the same side that you were treating before, off the midline and medial to the posterior superior iliac spine. So I'm primarily going straight down, maybe just angling a little bit towards the outside of the hip. So it's 99% going straight down and maybe 1% going laterally. That'll help you to decompress the sacroiliac joint as well. And you focus on going straight down. I chose to show you this image of the latissimus dorsi with its attaching tendon as it goes into the spine as well as the sacral area. If you were to look at the sacral ligaments that we've already treated at its deepest layer, on top of that is the tendon of the attaching latissimus dorsi. On top of that is the thoracolumbar fascia. All three of these areas at the posterior sacral area, as it goes into the back, are all very similar tissue. They have a tensile strength of over 2,000 pounds per square inch. They don't stretch. They have a little bit of give to them. They don't have very much nerve innervation. And they don't get very good blood supply. So when they get injured, a lot of times they stay injured. So we have a dysfunctional sandwich of ligaments, tendons, and fascia. So this is one area of the body with all this different layers of dysfunctional tissue that requires a lot of attention.
This is the sacral fascia, the fascia that covers the sacrum. So if this is the tip of the coccyx and here's the PSIS, then we want to work just off of the midline, exactly where we were before when we were doing the cross fiber stuff. But now we want to just be straight down into the fascia to release this, one layer at a time, minimum of 2 minutes. So you can either do it with your fingertips, you can do it with the heel of your hand, or you can do it with your elbow. But one thing's for certain, do not touch that posterior suprailiac spine. It's way too sensitive. I like to go on the other side of the body as well too, and with really good leverage. So if here's the PSIS, here's the coccyx, here's the midline. I'm going to be just lateral to the midline on the right side. And I'm going to go just straight down with my fingertips, using my body weight to do all the work for me. And if you don't have the fingers for this, then use the heel of your hand or use your elbow. So I'm going in really slow because I know this is kind of a sensitive area. Pressure okay?
Yep.
So it's about 3 pounds. You want to try and hold this for as long as you can. So you're patient, you're not rude. Don't go barging in. And you should start to feel this release within a few seconds. It just kind of comes like in waves. Are you feeling anything?
Well, no, it's not uncomfortable. It's pressure.
Are you feeling anything let go or relax?
There, that's on the left.
Did you? You said what? Could you repeat that?
It felt on the left that it gave away a little.
Mm-hmm.
What a coincidence. So I'm up to about, well, let me ask you, are you aware that I've tripled my pressure from when I started?
No. Feels like a lot less than when you were doing that last one.
Really? See how white my fingers are turning? Did you feel this? It just happened just now?
No.
Okay. It's all right. It's a unique feel, isn't it? Is there any way you could describe this to people, what this feels like?
Kind of like an elephant standing on my back. It's hard to not want to fight it.
Okay. Good job.
Quadratus lumborum. I found a cadaver dissection video that helped me to realize the importance of the quadratus lumborum and also a very unique structure called the lateral raphe.
When we reflect the multifidus in a superior direction, we can see all of the apophyseal joints, and the white tissue is the joint capsule, and we can see portions of the multifidus musculature which are related to this apophyseal joint. If we come back to our posterior layer of fascia, we can note now that it has traveled anteriorly to attach to the lumbar transverse processes, thereby completing our envelope, which started at the spinous process and ran around the erector spinae musculature and multifidus musculature to attach to the transverse process region. deep to the middle layer of fascia, which from the perspective of the human body is actually anterior to it, would be the quadratus lumborum muscle and the iliolumbar ligament. You can put the multifidus back over the dorsal surface of the sacrum, the deep portion of the erector spinae musculature, iliocostalis and longissimus, superficial portion of the erector spinae musculature, and posterior layer of the fascia. Now if we pull up the posterior layer of the fascia and take off the erector spinae aponeurosis, the deep portion of the erector spinae musculature, and the multifidus, to follow this posterior layer of fascia downward toward the transverse process, we come to a very important corner, which is a junction of the posterior or superficial layer of fascia and this deeper layer of fascia. That juncture is known as a lateral raphe. And the lateral raphe is one of the origins for the transversus abdominis and internal oblique musculature.
The purpose of this lateral view is to give you an idea of the way in which the latissimus and the abdominal musculature interact with the lumbodorsal fascia at the lateral raphe. To orient you a bit, we have our spinous processes here, sacral process, spinous processes here, the posterior superior iliac spine here, and the iliac crest here. This is the posterior layer of the lumbodorsal fascia as it moves lateral around the erector spine musculature to this vertical line. This vertical line is the lateral raphe. It is this line where a posterior force, a middle force, and a lateral force converge. What we'd like to show you here are the attachments into this vertical line. The latissimus dorsi from above comes down into the iliac crest as well as into this lateral raphe. If we reflect this tissue back, we can see this area here where it has its attachment. On this plane then is the external oblique. The external oblique has its origin back into the iliac crest and lower rib cage. As we reflect this superficial layer of the abdominal wall back, the next layer down then is the internal oblique, whose fibers travel superior and medial. Here's the iliac crest. The internal oblique travel this way and also have attachment as well into this vertical line. If I place the probe underneath the internal oblique and reflect it backwards, we then see the transverse fiber orientation of the transverse abdominis. Transverse abdominis is the most interior portion of the abdominal wall, and fibers all run in a transverse plane around to the linea alba. So the transverse abdominis has attachments as well into the lateral raphe. The next layer up is the internal oblique that has attachments to the lateral raphe. These two layers together form a laterally directed force to the vertical line or lumbodorsal fascia. The next layer is the external oblique, which does not attach into this region, and the latissimus dorsi from above, as it has its attachments to the iliac crest and as well as into this vertical line. There appears to be a significant interrelationship between the convergence of these forces at this region and the contractile forces of the musculature that we've outlined earlier as to the stability of the lumbopelvic region.
This is the posterior layer of thoracolumbar fascia meeting at the lateral raphe with this deeper layer which is attached to the transverse process. We've cut the middle layer of fascia and continue to pull it back, lifting up the medial extent and now exposing the quadratus lumborum muscle. We can see the quadratus lumborum muscle is attached to the iliac crest inferiorly and will run superiorly to attach to the 12th rib and medially to attach to the transverse processes of the lumbar vertebrae. The quadratus lumborum is not usually thought of as a back muscle important for its mechanics. However, it can be seen that it is another anchor, a type of stabilizer in the frontal plane, as it connects the lumbar transverse processes with the ilium. As we go more inferiorly toward the region of L5 and L4, there is a noted absence of the quadratus lumborum muscle, which instead is replaced by thick ligamentous tissue. This is the posterior extent of the iliolumbar ligament, which is attached to the transverse processes of L5 and the iliac crest.
This video was produced in 1990 by ECI Incorporated out of Carrollton, Texas. I tried to find more information on this video and I couldn't find anything. 2 years later, this company ECI went out of business in 1992. So this video literally is non-existent, not able to find it anywhere. There's been much data written about thoracolumbar fascia and its influence of back pain, which was interesting to see in the video. What I didn't realize, though, was this unique structure called the lateral raphe and how it influences everything too. The lateral raphe attaches pretty much from the middle to the posterior layers of the thoracolumbar fascia. There was an interesting study done by Warren Hammer. Not so much the study itself, but the image that I was able to find with that shows the middle and posterior layers of the thoracolumbar fascia, and how they all kind of meet and converge is very unique. That's where the lateral raphe is. So if you were to go from the center spine of the body to the lateral side of the body, halfway between is where the lateral raphe is. It almost appears to be like a stabilizer. If you were to look at the quadratus lumborum, that attaches the transverse process of L1 through L4 to the iliac crest. So if it goes laterally from the main structure, that's a support for it, kind of like the guide wires of a tent. At L5 transverse process is the iliolumbar ligament, that nasty sensitive ligament. And that goes laterally, so that helps to support the spine as well. So to look at all of these structures that go laterally that help to support the spine and the lower back, I would say the muscular stabilizer for the spine is quadratus lumborum. The ligament stabilizer for the spine, I would say, is the iliolumbar ligament. And the fascial stabilizer for the spine, I would say, is the lateral raphe. So with quadratus lumborum, it's difficult to treat because it's underneath the erector muscles. So if you go from the center of the spine to the lateral side of the body, halfway between, that's the spot. It's just below the ribs and just above the iliac crest. It's a very small space. It's good to treat this in the lateral side lying position. It opens a space up a little, but you can still treat it in the prone position too. And it's very sensitive on some people. You have to go in slow and just let it soften. The quadratus lumborum. It's probably not the most effective. There are other ways to work this, but you can only get 2 fingers or maybe 1 thumb in there anyway. It's at the spot in between the ribs and the iliac crest. So if you walk down the ribs where you fall off, there it is. If you walk up from the iliac crest and you fall off, there it is.
If you go from the center spine of the body, the middle, to the lateral side of the body, halfway between, there it is. So now all you have to do is just go 45 degrees into the center of the body and you got it. With some people that their back muscles are really thick, you might have to go a little more lateral and then just going in like that. Sensitive?
Yeah, a little bit.
A little bit?
Yeah.
So just kind of hold that spot. Remember, we're knocking on the door. We're not barging in. We want to be patient and polite, not rude. And as that lets go, then we can sink in even a little bit more. Sensitive spot. And as you saw in that video, there's a lot of it to treat, but this is all we can get unless we have a scalpel. From here, you could go in a straight line up to the medial border of the scapula. That's the lateral raphe. But now you're on ribs, so you have to really be careful. You don't like that? Sore?
The erector spinae muscle. People don't realize the erector spinae can become very thick because it has to stabilize us and hold us up and counteracts the negative effects of sitting. And 9 times out of 10, people can handle very good pressure when you're treating this sensitive area. I like to use my forearm here. If you place your olecranon, the tip of your elbow, into the lamina, then you'll be assured to treat the erector muscles, going up to the base of the scapula. It can be very thick on some people. Looking at this image, I looked at the sacroiliac joint and the posterior superior spine, and if you went straight up, you're going to be coming to the medial border of the scapula. So it's just lateral to the erectors, and that's where you'll find the lateral raphe. So anything medial of the lateral raphe is all erectors.
The erector muscles, the paraspinals. So halfway between here and here is right here. So they're right here. This is one area that they can usually handle decent pressure. So I take my olecranon, my elbow, and place it right into the lamina groove, just off of the midline, and I'm going to just lean right into them. Back to my favorite position, to where I could be eating a sandwich, reading a book. Sensitive. With some individuals, a lot of athletes that I see, like professional cyclists in the Tour de France, because they bend over so much, Lance Armstrong's erectors literally could be 2 inches thick. Wow. And you can just lean right into them. They just love it. Now, if you went a little more lateral, you can't lean into it because you're not on the muscle. Now you're on the ribs. So going up this way to the base of the scapula, now you're treating the lateral raphe, especially people that have scoliosis. This lateral raphe can be really contracted and really tight. And if you see anywhere on their intake form, osteo something or other, do not touch those ribs. There's a condition called osteogenesis imperfecta, the brittle bone disease, that you just touch the rib and it could fracture. It could break. You don't have that, but do they?
No. But that's burning.
Is
They
it?
will sneeze and it'll break.
Quadriceps. Quadriceps, because of its diagonal nature, it's wider at the hips and narrower at their knee, or what's called the Q angle. It's not uncommon that vastus lateralis, because of that angle, absorbs most of the stress and shock when we're walking, let alone when we're running. So by treating the lateral edge, it's usually much more effective and it influences the pressure on the knee. Sometimes people are not aware how sensitive their quadriceps are. It might require a little bit more sensitivity on your part. Going against the grain, on the inside portion, it would be medial to lateral, and on the outside portion, it would be lateral to medial.
So with quadriceps, they can be really hypersensitive at first, but they respond really quickly afterwards. They go diagonally like this. Most of the dysfunctional area is usually vastus lateralis. So use nice gentle strokes, and we want to slowly get in there, working with their tolerance. Up, using my hands again. So now we're using my forearms, and it's so much easier on me. Is that okay? It's a nice broad contact area. It's not as invasive. And sometimes we'll see some large quadriceps. This could be some of the strongest muscles we have. And they cross over top of each other, so they're always stuck or adhered to each other. Then we start going against the grain. So to release the lateral portion, I would go lateral to medial. And this is a little bit invasive. Good thing we can't see your face on the camera. I always look at a person's face first, long before they ever have a chance to scream. You'll see any dysfunction in the body on their face. Is that okay? To release the inside portion, which usually isn't much of a factor, it would be lateral to medial. I'm sorry, medial to lateral. Not too bad. Then I started thinking about this. If the quads are going diagonally, what's the exact opposite of that? So if you go from the lateral patella to the medial adductors, oh my goodness. And right here in the middle of the quads, there's a speed bump that I didn't even feel before. So I'm just going through it really slowly, trying to work with it. It can be uncomfortable, but it should never be painful. All right? Not using much pressure. This is about 3 pounds. And you can also start a little bit higher. Go into those adductors that way. Can really be sensitive. But they're releasing really quick compared to hamstrings, which take forever. You can also do dynamic extension of the quadriceps that work really well, but it's not to the truest sense of the word, because with the leg off to the side of the table, she has to hold the quadricep up, and slowly it's letting go. So best is probably side-lying position for that. So by bringing the leg, if you scoot towards me a little, it's just low, bringing the knee off the edge of the table like that. Now hold your leg up, so she's got to contract this. Now by using your hamstring, slowly bend your knee. As she slowly bends her knee, that's sending the neurological signal to the hamstrings, and it allows the quads to stretch. That's when you want to work it. And then again. But let the person do all the work instead of you. So it's like a 3/4 dynamic extension move, not 100%. Best way is you have to not engage the quadriceps. All you want to engage is hamstrings. But they're becoming more aware of this area proprioceptively that they've lost because they never realized it was so tight. Then try and go diagonal as you're doing dynamic extension. That like magnifies it 10 times. That's great. Really gets in there.
The anterior hip. The inguinal ligament treatment. Many therapists are taught how to work a person's hip flexor area, the iliopsoas. I myself have learned it, and I prefer not to use it. I feel that treatment is very invasive. You're pushing through the side of the abdomen. As the person goes into hip flexion, you feel that muscle pop up, and then you can cross-fiber friction it. It's very sensitive on most people. An alternate to that is that I started looking at the fascia that covers the hip area, and I prefer to treat that. It's a two-step process. The first is applying a little bit of pressure to the ligament and then shortening the area. The second part is kind of like a tissue re-education movement. People have commented to me that it's a lot less invasive, although it might be a little bit more time-consuming, and yet the effects are amazing. In the tissue re-education portion, it seems like it kind of reams out the acetabulum, especially with arthritic hip joints. It smooths that ball and socket out. And people that have commented to me that are bone on bone, that have hip replacements, surgeries scheduled, many of them have actually canceled their surgery because of this technique. Have to really utilize your sensitivity and work with the person. I'm honored to be able to show this demonstration video of an actual class of mine. The woman on the table had experienced pain and lack of range of motion for the past 20 years. When she got up from the table after this 16-minute demonstration, she had said that she's gained at least 80% more range of motion in her hips than she had before.
Next is the inguinal ligament. This attaches at the anterior superior iliac spine and the pubis. And the best way to find it is just to bend their knee. Where their material creases on their clothing or the drape that's over top of them, you'll know exactly where it is. It's also the underwear line. This procedure can be done over top of a drape, with shorts on, just a variety of different things. And we want to use a lot of sensitivity here. We're only using 5 pounds of pressure maximum. 3 fingers. Anything more than 3 fingers, then you actually run the risk of actually intruding into some really sensitive structures that unless you have specific training on how to work, you're better off not even going there. But 3 fingers, you're perfectly fine. So you won't risk pushing into the femoral artery, the femoral nerves, sensitive lymphatic vessels. But 3 fingers, you're perfectly fine. So from the ASIS, go just a little bit inferior, 3 fingers. You want to try and go into the center of the hip, not as much into the center of the body. The center of the hip, as you're moving the leg around, it'll ensure that you're staying right where you should be. I also want to have a straight palm, because when you bring the leg around in different positions, you're going to run out of room if you have a cupped hand. So you have to have a straight palm, just like Bruce Lee or Jackie Chan. Okay? So go into the center of the hip, straight palm, 5 pounds of pressure max, almost nothing. Because as you move the leg, if you find a tight spot, it's going to actually increase the pressure without you having to do it. So then once you find this spot, 5 pounds of pressure, going into the center of the hip, straight palm, then lift the knee, and this area should actually tighten up a little bit. You should feel it. Now instead of lifting the leg, because the leg literally could weigh hundreds of pounds, so you're going to cup your hand and go just below the knee, the patella, and you're going to push the knee in different positions instead of lifting the leg. Push. Keep your constant 5 pounds of pressure on, and we're going to the mid position here, and just allowing her to get used to that 5 pounds. Doing okay? From here, if I think of the center of the hip kind of like a clock, then I'm going to slowly lower the leg to 9 o'clock. And we're just going to just wait. I could do this on a post-operative hip replacement person, but you have to just be aware of the movements they can't do. They can tell you, their surgeon can tell you, with a lot of anterior approach hip replacements, it's not an issue anymore. But still be aware. So you're working with the person though. If they can't do it, then you can't go there. Some people, geriatrics, have a very small range of motion, baby ranges. But if the person can handle it, take them to their fullest edge. Anything more than 5 pounds, this would be way too much pressure. But 5 pounds is perfectly fine. Then we're going to move the knee up into 10 o'clock position. Try and make sure to let it go. How's it feeling? Is it okay? Little sensitive or not too bad?
Not too bad.
Do you just feel the pressure where my fingers are?
Yes, it burns.
It burns? Okay. So that's kind of released a little, 5, 10, 15 seconds. Go to the next position. 11 o'clock. It's not uncommon that you'll find at least 1 to 2 spots that are really sensitive. So you might want to go back to those spots again. A lot of people comment maybe 11 o'clock, maybe 1 o'clock. So far, so good? So 11 o'clock here seems to be pretty good. Still a little tight, but not too bad. Ooh, little spot there.
I feel my right hip is relaxing.
Is it?
Oh, my, this one.
Your
moves
left
it.
hip is relaxing
Yeah.
a little? The opposite hip. Now we'll go up to 12. Oh. So that was really tight. So what I'm going to do is I'm going to back up to about 11:30 and I'm going to slowly creep into that spot. If I can't get to 12 this way, then what I could do is I could go around the other way and then come in from 1 o'clock and see if I can slowly creep into that 12 o'clock spot.
When you say
Go ahead.
tight, you're talking about what you're feeling with the knee in terms of resistance, or what you're feeling with your...
No, I actually feel the inguinal ligament tighten up.
Okay, gotcha.
Yeah, that whole area just tightens right up.
Okay.
Did you feel like a vein just...
Is it better?
Yeah.
Isn't it nice, though, that I take it really slow and I don't go in there too fast?
Right. So you haven't moved your fingers at all. It was just in that same spot.
Yeah, yeah, I kept my fingers right there. Now we're going around to 1 o'clock, and she doesn't like that one, so we're going to back up a little bit and slowly go in there. Still don't like that spot. Better.
Yeah.
Slowly getting in there.
Oh.
You're making me look bad. Because I said this was uncomfortable, not painful.
I told you earlier it was really bad.
I know. That's why I want to work with you. 2 o'clock is not good. Do you notice that I can't get full range of motion? I should be able to get her knee over here. She can't handle that. So I'm not going to push her. I'm taking her to her edge, but I'm not pushing her any further than that. There, too. It's like the whole left side of the clock is non-existent for her. But going right to that edge, just past the midline of that clock, it's tough for her, but she's doing it. She's doing a good job. So that means when we go around again, she's going to have better range of motion just from doing that. How's that? So that's about 3 o'clock.
That burns.
It burns. Do you feel it in the front or the back?
Right there.
Okay. 4 o'clock. Some of the lower positions that you'll go to, like 4 o'clock and 5 o'clock, the foot is actually touching the table. If that's the case, then just unbend the knee a little bit, and you'll be able to get to those other positions. No more than 5 pounds. 6 o'clock. 7 o'clock.
Good.
8 o'clock.
Good.
And 9 o'clock. So, first part. The second part is just a tissue re-education move of moving the leg to different positions, and it's going to stretch, and it's going to kind of lubricate this hip joint. And it'll get everything. It'll get the leg, the ligaments, the tendons, you name it. So we go to mid position, You sure you're all right? You want to do this? So mid-position here, now what we're going to do, instead of just doing that range of motion, on her, maybe this probably isn't a bad idea, just doing that. But let's put a little torque to it. So I'm going to pull the knee towards me, and I'm going to push the ankle away from me.
Oh.
So we're externally rotating her hip. So she feels that everywhere. Do you feel it more in the back?
Here.
Right there in the front. So we're going to go down to 9 o'clock. Let it go. There you go. But you see, I'm not pushing it, am I? I'm just holding it there and had her let go. So when she let go, if I would have pushed it, she would have like tightened right back up again. She's like, I trusted you. So let's see, can she go any more? Well, maybe just a touch. Yeah, there we go. So this is probably longer than 5 minutes. So especially this demo too, but the average is 5 minutes. There you go. She's experimenting with it. Her body is really tight, and then all of a sudden she sees I'm not going to move or anything. I'm not going to do anything fast or funny, and then she lets go a little bit. It's one layer at a time. So I remember that 12 o'clock spot was not good. So we're going to try and go up a little bit to 10 o'clock. And you want to keep this external rotation as much as you can. And now we're getting into my favorite hamstring position, or stretch, which is called happy baby. So with this one, the person could do this at home. They would take their hand and push down on their foot. And then if they do both legs at the same time, then they look like a happy baby. And it really gets into those hamstrings. You all right? Still there? So we'll go up to 11 o'clock. Try and keep that torquing going. Make it a little easier. I'm actually putting my elbow into my side to give me a little leverage. If you have to, you can get on the edge of the table and just put your body into it.
It's like, gonna get kicked.
She's not liking that 12 o'clock spot. Take it nice and slow. There we go. She's going to feel so good afterwards.
It hurts.
This is like a better back yoga class in 5 minutes. But for her, 15.
Oh.
So we're trying to get to 12 with that external rotation. All right, let's try the other way. So we go down to 6 o'clock with external rotation. So where do you feel that? Front or back? Front.
They're all right there.
Right there. Then we go over to 4 o'clock. Same place. See, if we would have done the other leg, then we would have been done already. She doesn't have this problem with the other leg. That's all right. I'll push it to a point, but not over that point. So you got to find out that we have a communication going on, that she'll let me push it a little, but you don't take it over the edge. There is no way I'm going to take it over the edge. I'm working with her instead of working against her. You're good. You're good. So we're just past the midline. So this... All right, let's go back around again. So give her a break. You all right? So next thing we're going to do is the second part of this. So the second part of this is we've already done external rotation. Now we're doing internal rotation. Internal rotation of the hip will get everything else that the external didn't, but the one precaution is the knee. Sometimes the knee, it puts a little extra pressure on that. So keep asking them if the knee's an issue, then you just don't torque it as much. So we go to mid position. I'm going to push the knee away from me and pull the foot towards me.
Keep going.
What's that like?
Yeah.
Wow, you're good at this.
It's still there, but it's better.
Okay. This is hard to do. For a lot of, we never do this. So mid position, now let's go to 9 o'clock, nice and slow. Let me know if it's too much. Is the knee okay?
Yes.
Can you just let your hip go? Let it go. There you go.
Oh.
Can we go up with it?
Yes.
Okay.
Oh.
No, we can't, unless you let it go. There we go. Do you feel that's still in the same place? In there?
All the way goes right there.
Okay, is the knee okay though?
Yes, the knee's okay.
Now, if the knee were a little bit too much, well, then you just don't torque it as much as you're going up. Okay, now you did this before, so what we're going to do is we're just going to go to this position that she can do, then we're going to torque it. It's kind of subtle, but boy, what a difference. It's like she's going to have a new hip when she stands up. I don't think I would call it strain counter strain though. Go ahead.
So you just do this anytime somebody has tight hips or for anything else specific?
Oh, you could do it it's specifically for sciatic pain. If they have tight hips, yes, you could do that. I especially like to do this with arthritic hips. They love this. Sometimes they've even canceled their hip replacement surgeries because of it. Sometimes the hip will clunk. But the precaution is be careful about hip replacements that have had their hips done, and especially knee issues. If the knee starts bothering them, just don't torque it as much as you're going around. But it's great for arthritic hips. I think she can get to 12 o'clock easier with internal rotation than she can external. What I really want to do is get to the other side of that clock, to that 3 o'clock side.
Did she have an injury to this hip to make it so?
Yeah. Ooh, she's doing it. All right. Because I can get better on internal rotation than I could with external. Good job. Still feel in the front?
It's going all the way back here.
All the way in the back in the
Yeah.
glutes?
Right here.
Okay.
Right there.
That's great. Okay, you did it. Excellent job.
Good job.
I like to finish up a treatment with active isolated assisted stretching. It only takes a few minutes. The gentleman that taught me this said that you only want to hold a stretch for 2 seconds. That way you're not invading what they call the stretch reflex, to where it has a tendency to tighten up even further. But if you're only holding it for 2 seconds, then you should just do it more often. So maybe on an average I'll do a stretch 10 times. And each time I do the stretch, I can usually get into it a little bit further. If you happen to have my course manual, you'll be able to see all of the stretches in detail with easy to follow instructions. These video demonstrations are the most commonly asked for clarification. With gastrocnemius, if the person shortens their tibialis anterior, that brings their foot into dorsiflexion. When they relax, then I just stretch the gastroc. With hamstrings, in this position here, if she could shorten her quadriceps, that's going to straighten her knee. When she relaxes, at the end of that, then I give her a little push forward to stretch her hamstrings. An alternate move to that is at home by using a band or a rope or a towel to provide a little bit of resistance as they do the stretch themselves. Always one of the best hamstring stretches is Happy Baby. This really gets into the common hamstring tendon. So if she pushes down on her feet, then she feels that stretch all the way in through there. Quadratus lumborum stretch. If she contracts the opposite side of the body, then when she relaxes, that's when I give her the stretch. Feeling it into the IT bands, side of the glutes, and sometimes into the lower back. Quadriceps. If she contracts her gluteus muscles to go into extension when she relaxes, that's when I lift up on the knee to stretch the quadriceps and the anterior hip. Anterior hip and leg. If my hip goes into her sacrum, that helps to support her lower back. And then all I have to do is rotate my body to stretch. If she were to hold on to her bottom leg with her hand, that minimizes the movement of the ilium and it provides even a deeper stretch. It magnifies the stretch even more. This is an isotonic active stretch. So if she holds her leg up and I'm going to push down on her leg and she resists me with only about 30%. So I can still do the movement. She's resisting me a little bit. It has a tendency to kind of reset the nerves in the lower back.
If I wanted to stretch her gastrocnemius, if you tell her to contract the opposing muscle, that's tibialis anterior. So if I were to tap on her tibialis anterior, that tells her to contract that. Now she's going to go into dorsiflexion. When she relaxes, then I give her the stretch. And then relax and then do it again. Nice and relaxed, no strain in my body whatsoever. Each time that I do this, I can actually stretch it a little bit more. So however you feel, if you want to hold it longer, shorter, whatever. If I wanted to stretch this side of her body, I could do that by grabbing her leg and pulling it over. The problem is the other leg is in the way. So if my fingers are on the top dorsal part of her foot that I want to stretch, then I place the offensive leg on my fingers. Now to make sure that her hip stays in contact with the table, I'll counterbalance by putting pressure on her hip and then slide her off the table. To do active isolated assisted stretching with this, all the muscles on the opposite side of your body, if you would, bring your legs towards me. Relax, let it go. And then again, all towards me, relax, let it go. Good stretch, isn't it?
Yeah, it's nice.
So I want to stretch this side, so my fingers go here, offensive leg on my fingers, stabilize this hip. With all the muscles on this side of your body, push your legs towards me. Relax, let it go. And then again, towards me, relax, let it go. Next is side lying position. So with this one, you want to make sure that you stabilize their lower back really well. If the table is the same height as your hip, then you're okay. Then you just rotate your body. If it isn't, then sit on the edge of the table to protect the lower back. It's like you've got to be sandwiched in here or you're going to be in trouble. So I'm going to take this hip and place it right at her sacrum to protect her sacrum. Then I'm going to practice by rotating and looking behind me. I'm going to feel my obliques tighten and look behind me. That's a secret, is to look behind you. because that'll give you that little bit extra. Now we're going to bend her and look behind me. Just guide her leg around, and then we're going to look behind me. Feel okay?
Yeah, feels good.
To do active isolated assisted stretching with this, go to mid position, and by using your glutes, push your leg back towards me. Relax, let it go. And then one more time. Relax, let it go. If you really want to isolate this movement, if you were to grab onto your knee with your hands, that's going to isolate the movement of the ilium. Push the leg back towards me, relax, let it go. And you can't even stretch it hardly half as much, but she really feels that.
Yeah.
Okay, other side. So make sure your hip is into their sacrum. Practice rotating around, feel your obliques tighten, and look behind you. That's the secret. Make sure your hip is into their sacrum. Practice rotating around, and then look behind you. By taking your bent knee with your hand, that isolates the movement of the ilium. Now push your leg back towards me using your glutes. Relax, let it go. And then again, one more time. Push, relax, let it go. Yes?
Yeah.
Good.
Kinesiology tape treatment. This is an optional addition you could add.
All right, so you want to make sure the person is really in extreme hip flexion. So remember that this one glute is draped, so we're exposing one glute because we want to do this on skin. So I pull off one of the pieces of tape, and this KT tape is pre-scored. So I'm going to fold it where it's scored at, where it bends, and then I'm going to just tear the paper backing. Then I'm going to take and I'm going to, as I'm tearing the paper backing here at this K part, then I'm going to be stretching the tape because it's flexible. As I'm stretching it, I'm also tearing the paper on the other side. So then I'm going to peel that off. I'm going to place this at her ischium bone. And because she's in forward flexion, you don't have to stretch it even more. Now, instead of fumbling with it and having it stick to itself and getting frustrated and throwing it away and have to get some more tape, once it's anchored to one side, all I have to do now is just take the paper and pull it down like that. Now it's pre-stuck. Now all I have to do is come back, and I'm going to move this to make like a little heart or a teardrop. And you want it to be right in the center of the glute where the sciatic nerve is. And that's it. That way you're not fumbling with it. So I pre-stick it, and then you can always move it back. It's really strong stuff. It works great for a lot of different areas.
Self-treatment. I like to include a little bit of homework that the person can do on their own. I would rather give them 1 or 2 moves, but have them do it every day for a minute or 2. And they get used to doing it, they start feeling better, and then they're more encouraged to do even more. They've actually come up to me after and said, after a week or so, I'm feeling really good, you got some more stretches you can give me. So instead of giving them too much, I would rather give them 1 or 2. So good morning exercise would be great to do in the morning before they get out of bed, and it helps to strengthen their core muscles, which takes pressure off of their back. Dog and cat is good for general flexibility. The warrior stretch helps to stretch out the front of the hip and the quad to take pressure off the back. Hamstrings, if the hamstrings are a big issue, there are tons of different stretches they could do for hamstrings. This is just one of them off the side of a chair. Cross foot is good for stretching out the lateral rotators, or also the pigeon move in yoga, Cross leg is good for the IT bands, the glutes, and the sacroiliac joint area. I hope you enjoyed this course, Effective Treatments for Sciatica. Please feel free to contact me through my website, advancedmassageeducation.com. You can leave me an email. I also wrote a book on stretching called Stretch for Success. You can download it for free. It's a PDF form. And the different courses that I teach, as well as different reviews and a blog that I write about too. Thanks again.